Hello, everyone. Thank you for joining us. I'm Dr. Debbie Hamilton, and I'm very excited to interview Pete Williams today about a subject that I don't think any of us know enough about in terms of oral health and its connection to systemic health. So I'm really excited to see what we can learn and kind of go through and treatment and all that other stuff. So welcome, Pete. You can introduce yourself and
well, thanks for the introduction. Can I just say that I really love your company, use a lot of your products, and they consistently give great results. So thank you for that, and thank you for allowing me to chat tonight. So let me give you a very brief background. I've got sort of two sides of my academic journey, if you like. I originally started off as a sports scientist. Mm-hmm. Then decided I wanted to be an exercise scientist. So I did a couple of degrees in that. And then really for, I suppose, the last 20 years, I got introduced to the Institute for Functional Medicine. God, that was 1996. I went to a lecture, Jeff Bland, actually one of his first lectures in the UK. And that was it for me. I had a very small, if you like, I suppose we could call it a lifestyle medicine practice in the central London. And that was my progression really into this understanding of maybe all things are connected. I remember seeing Jeff, he did a lecture on the heart was on, I think it was actually called The Heart Was on Fire. This was 1995, 96. Yeah. And it really blew me away. It blew me away that, wow, everything that I knew and everything I was taught maybe wasn't the truth. And here's a man so eloquently delivering something. I couldn't stay still in the lecture, and that was it for me. So I've gone right down the IFM pathway. I was certified in the first group actually in 2013. I just knew it was my calling. And since then, I've done quite a lot of work on the Bresden protocol as well. I was one of the early adopters of that. We've got a central London practice, functional medicine practice in central London. It's been well established. We've got quite a lot of IFM certified practitioners that are on board with that as well. And so I suppose today's subject was a combination of all of that training, if you like, but also that I've always been interested in cognitive decline, Alzheimer's, and I think that was again through IFM training, but also through the Bresden training. And for the fact that I think in my early 40s, I definitely started to see some cognitive issues, definitely around memory. And again, looking through that training of the Bresden protocol, the IFM protocol, and understanding a lot more about me and my genetics. I've got a very big concussive background because I played a lot of contact sports as a kid, and so it all sort of fitted. And again, understanding the genomics and ApoE3, E4 genotype, so it all started to fit the picture. And then actually around about 2016, literally after probably a couple of months after I did the original Bresden training, I started having a problem with the back tooth. Never had any problems with my teeth before, and in fact, I always felt that my teeth were in pretty good shape. Went to a dentist, local dentist that I've used, and again, regular dentists go at regular hygienist. Go nothing particularly wrong with my teeth. Yeah, maybe a bit of some biofilm, but nothing serious. And then the dentist said, "Well, Mr. Williams, we're going to have to take that tooth out." And I thought, well, okay, look, I've got good teeth. I'm 45. I was 45 at the time. This was 8 years ago. What's the problem? And she said, "Well, I think you've got quite significant periodontal disease at the back there." And so I think two things that immediately hit me. Number one, I suppose the embarrassment of someone telling you, number one, you had a disease, but number two, the real embarrassment that Debbie, I had absolutely no idea what periodontal disease was. And so that was more of the shock for me. It's like, here's someone who should sort of understand, quite well how it all fits together. I had absolutely no idea. So I suppose today's lecture is partly because of the embarrassment of that conversation, and then going straight home, straight onto PubMed, and then PubMed completely opened me up to a new world and a new rabbit hole with regards to gut periodontal disease, and not just periodontal disease as a local disease, but periodontal disease and its associations with other disease processes. And not just that, also the sort of the bidirectionality of gum disease and other diseases. And suddenly it's just really, really opened that up for me. And I look back, as you say, I've been in clinical functional medicine practice for 2 decades. And I look back at all of those patients beforehand, the obese patients, the type 2 diabetics, the rheumatoid arthritis, and of course, the cognitive decline patients. And a lot of them, I've done a good job, did a good job with them, but I could have done a better job. And the reason why that is because I never, ever asked that question in clinical practice, which with regards to, the health of your mouth. And probably, probably like the US is that, well, surely that's a dentist's area. And the reality is, well, so yes, it is. But the reality is now is that even in dentistry, and I don't know what dentistry and how that's changing in the US, but certainly in the UK, certainly some of the dentists I work with, they can no longer ignore the science that shows just how, if you've got poor dental health, how much that influences not only the progression of the dental health, but also the progression of the other diseases. And there's, in particular, there are some organizations and there's some researchers in the US, which we can talk about later, that are actually looking at other diseases and the influence of bacteria, oral bacteria, and how they maybe are be causative in nature. And when I mean causative, they are not the only cause to a disease process, but they are certainly being causative to some degree of the mechanisms that drive those processes. And so I suppose I've just got to the point where, again, from a personal perspective, I've been looking at this now quite heavily for 8 years. And so much so that, not so much originally because I wanted to do something around gum disease, but I wanted to create something that gave me a much better understanding of how individuals, my patients with gum disease and other diseases, understand that gum disease in a lot more detail. So I wanted to get an understanding of, in very simple terms, who's on the battlefield, who are the pathogenic bacteria that might be creating the problem, and then most importantly, how is your unique defense system, your defense force, going to react to the bacteria? And so obviously I know quite a lot of people in the industry, because I've been in the industry for a long time. And so I spoke to some of the genetics companies that I know, and we developed DNA Smile, which is a genetic panel that is very well. And what I would say on that, it's a genetics panel that is still is always going to be in progress, because more data comes out, more research comes out, and more changes may need to be made to that panel. But I think as we are at the moment, we've got a really nice, robust panel that is not only giving you that understanding of that unique signature to your immune system and how it's going to react to bacteria. We developed a clinician's course, really simple course that gets them to understand, well, how does this DNA panel work? Right. And how does that DNA panel work within the sort of the bigger picture of functional medicine? And, how do you look after patients? And so that's really where we started. And I suppose that leads us into, the oral systemic relationship. The connection, right? Yeah, and I think that leads us into also, I suppose, where nutraceutical companies are moving, because again, I think like your Oramax, I've got it here. Yeah. And I would say not just nutraceutical companies, because actually, if you look at pharmaceuticals, there's a trial on it at the moment, still going through 3rd and 4th phases, called the GAIN trial. What's very interesting about the GAIN trial, I think it's actually, maybe we might be looking at a medication that may have therapeutic benefits to Alzheimer's patients. And obviously, as you know, all drugs haven't worked with regards to Alzheimer's. And I think Dale explains that incredibly well, because like every chronic disease, it's multifactorial in nature. Right. And this new drug that has been designed, it's been designed to try and influence some of the toxic effects that you have from a very specific oral bacteria called Porphyrovirus gingivalis.
Right. I was actually just looking at that, so I think I know what
Yeah.
I know what you're
So
talking about.
the GAIN trial is really interesting because obviously, you know, one of the, I suppose, very simple key effects that you can take away is really as we get older and we start to lose our teeth, that is very much associated with increased Alzheimer's risk as well. And so the GAIN trial is really looking at, can we find a medication that actually changes the way some of these toxic bacteria influence the outcomes? And I'm going to talk about that later. Some really incredible literature that's come out. I look at it differently, Debbie, because not only do I think maybe that drug, if the safety side looks good, has a place to play, but my question would be, well, wouldn't you want to find out who's on the battlefield first?
Right.
And
which
are
bacteria?
are there more natural ways of looking after that, which I think, you know, is very much what nutraceutical companies are looking at. I think your Oramax is a if you like, a combination of if you like, here's the strain specific armies that we use to deal with some of the bacteria, which again, I think is really important, because I think if we're looking at the probiotic world, I think we've definitely moved from just take a probiotic. I think we're saying, okay, so maybe here the strain specifics that we know in the research will deal with these bacteria that we want to. I think that's really important. But also what I like about your product as well, which beautifully ties into my thought process originally when I was looking at developing DNA Smile, is that you need something that is you need additional soldiers that are going to be perfectly designed to fight against certain bacteria. Brilliant. But then what you've got to also know is, well, what is my unique signature of my immune system is going to react to the bacteria?
Right, the inflammation component.
Yeah, of course. And that's not just from an innate, that's from an acquired aspect. And that's what I like about, again, with the detail in the Oramax, is that there are specifics in there that are designed to actually calm some of the cytokines that are definitely going to produce when that innate and that immune system chooses to react. And what I would say on that, again, is that I think this is where Oramax ties in beautifully to people who are going to be more prone to gum disease, and more, because the likelihood is the reason why they're prone to gum disease is twofold. Either they got significant amounts of pathogenic bacteria, or they've got a very overreactive immune system. And again, I think we can take this back and talk about gum disease, but we can also talk about the same mechanisms that have been problematic in, I mean, just a very simple example would be when we had Delta for COVID.
Yes.
We knew that the people who unfortunately had the most adverse consequences to that were the ones where, again, they probably generalized, had higher levels of inflammation.
Right.
They probably had some comorbidities, but they also had an immune signature that was overly aggressive, and therefore too good at fighting, likes fighting too much, but importantly doesn't like to switch down. And so what I think we're looking at is that, for me, you know, if we talk about I believe the oral health is the new gut health. I don't think we should separate them. And one of the
that's the thing, though. I mean, the mouth is the top of the digestive system, and people forget that.
They totally forget.
You know,
that. But
you get dysbiosis in the gut. You should be able to. Why wouldn't you have it in the mouth the same way?
Absolutely. So I look at this. I never separate it. Yeah. And what I look at it is that your mouth is the very first battle that happens to the human. The human has to defend against the outside world predominantly through that gastrointestinal tract, this tube that allows your immune system to talk to the outside world. So it's really important that we have a decent understanding of that. And it's really important that we understand what is happening in the mouth, because what is happening in the mouth is likely going to be happening further down. In the gut, right. And so as you say, I have taken a very particular interest in this. And the reason why certainly from a point of view of testing for pathogenic bacteria, which you can do, and there's lots of companies, it's easy to do. But
I mean, that's
also,
my question too. How do you test for, what different bacteria
there
you
are
have?
several companies I would recommend. The one that I have a good relationship in the US is Oral DNA Labs. So I actually import their test because I find it really easy to use. It's very patient friendly. You can do it in the clinic, and I think it sometimes reminds me of where we are with microbiome testing. I think sometimes the technology is a little bit more advanced than actually the clinical data that you can get from it. There are a lot of assumptions. So there's nothing you can't test for, but actually I don't know how much of what you test for becomes noise, because there's only a certain amount of stuff that you can read that is clinically meaningful. And I think Oral DNA Labs do that really well. So I know I'm giving the plug, but I've had a good relationship for them for several years now, and they've been brilliant. And they're definitely my go-to because it's a cheap and easy test that gives you that real picture about who's on the battlefield. And really what you're trying to work out from that is that who are the special forces and who are the new recruits that really are on the battlefield and maybe not going to do that much damage. But you want to know those special forces pathogens, those, we call them the red pathogens, like Porphyromonas gingivalis.
And which one are those? You mentioned that one. Are there other ones?
I mentioned that one. There are lots. Tannerella denticola. There's another one begins in T. Tannerella forsythia, I think, is the other one, and there's a few others. Can be very, very problematic for the host. Again, it's not just a question of the bacteria, it's a question of how the host chooses to react. But let's think about worst case scenario. If you have a lot of those red complex bacteria, the particularly virulent pathogens, and you've got an overreactive both innate and immune system genetically, then you're in trouble. And you may have not even know that, but maybe in your 40s and your late 30s, you've already developed gum disease. I want to talk about gum disease because I want to give you some numbers, because that will bring you back to why I felt that this is so important and why I think it's so important in clinical practice. Is that when you look at the literature, there's a 2020 paper, I think, in Scientific Medicine that looked at the rate of gum disease in high income countries. So, USA, UK, a lot of Europe. And what was really interesting about that is that when we looked at the numbers, over 40% of the adult population has gum disease, established gum disease. When you go a little,
that's a significant number.
It's a massive number.
Is it, when you say adults, kind of what ages are you thinking?
Well, that's the interesting thing, because of course, when you go to 50 plus, the number jumps again, because the thing about gum disease, it's a disease that hits individuals early. So it's developing generally from your 20s onwards. And what's very interesting as well is you're also seeing this in kids. What you're seeing in kids, again, you're seeing some really very bidirectional relationships with other diseases. So there's really some disturbing data that comes out when you look at child obesity and gum disease rates. And they again, these diseases are having bidirectional relationships because they're underpinned by the same mechanisms: excessive oxidative stress, inflammation, an immune response, an inflammatory response, advanced glycation end product response. And so there's a bidirectionality to many of these diseases. I read a paper last week that actually showed in some obese studies with children, they are 4.5 times more likely to have gum disease because they're obese. And again, like everything, there's a bidirectional relationship. And the reason why that is because the mechanisms that drive gum disease are also the mechanisms that drive obesity, type 2 diabetes, rheumatoid arthritis. So you take your pick. And so what we're looking at here is how that we need to get a good understanding of a localized problem, because that localized problem is never a localized problem. And I think this is why, again, I thought about this a lot, and I thought about, God, 10 years ago, I never asked any of my patients about their dental health, but it's standard practice for us. And yes, I've developed a gene panel that goes with it, and I've developed the clinician's course that goes with it. But the reality of that is, certainly in my patient group, And probably more than 1 in 2 who comes in with whatever disease probably has established gum disease.
Wow.
And so it's a very significant number. And therefore, it's something that's really important, that may be really a strong contributor to a lot of their problems. I want to just continue with that, because I want to just give you a very nice little case study. This is actually a case study of a rheumatoid arthritis patient that myself and what she calls herself, she's a dentist, but she calls herself a functional dentist. We've got a few of them in the UK, and they are dentists who understand systems thinking, functional medicine.
Right. Mm-hmm.
So this is a brilliant example of what I'm going to say on this. Of course, case studies are the lowest form of research as we look at them.
Number
but
one.
It was a life-changing outcome for this patient. So this was a female patient in her 50s. She had severe rheumatoid arthritis. She wasn't happy with the way the National Health Service in the UK was treating her, because the only treatment strategy was fundamentally steroids. And if they weren't going to work,
right,
the dosages were going to go up, and then it was going to be something stronger. She didn't like the way the steroids made her feel. And so she actually, a year before she came to see me, got involved with a functional medicine doctor. And to be fair, the guy did a pretty good job. And he did a full workup, as you would from a functional medicine. But, and this is no fault of his own, because 8 years ago I would have done exactly the same, he never asked the question, and that was, what was happening in your mouth? And this was a patient with severe periodontal disease. So when she came to me, with having done a very big functional medicine workup, spent a lot of money on testing, her symptoms and her numbers were getting worse. She had an anti-CCP level that was around 500, and she had a CRP of 26. Wow. Now, for me, that's not, almost, it doesn't really feel like a sort of mild inflammation that you would see with chronic disease. This feels almost like an infective situation.
More like an acute situation.
Well, exactly, yeah, and that's something that we pondered at the beginning. But the reality for me, the red flag was, I felt that it was the advanced gum disease that was the problem. And so I had to do all the workup that I needed to do. But I also said to her, look, I think this is the problem, and we need to get a dentist who understands what I'm going to do to work with you. It needs a double-pronged approach. And so we sent her off to the dentist, and the dentist started doing that. We used a DNA smile, so we saw some unique genetics and got an understanding why that was problematic, but also some of the genes that are much more associated with rheumatoid and autoimmune disease. She had a lot of pathogenic bacteria in the mouth, and so we did a really big full-pronged approach, and it was so successful, Debbie, that we got to the point in 4 months where she never flared anymore. She didn't need any medication. Sure, we had to do quite a lot of work. She was backed up nutraceutically. Again, interestingly, using stuff that the Oramax has now got involved with, particularly the green tea. So we had it like consistently drinking green tea, because we know it has an antimicrobial and antibacterial effect. But she was pretty much showing no rheumatoid symptoms at all within 4 months. She had a CRP leveling off around about 5. She had some reduction in her anti-CCP, not a huge amount, but she was predominantly symptom-free. And actually, funny enough, I had a conversation with her yesterday, and she's been symptom-free because I believe fundamentally that we dealt with the gum disease, and the gum disease is under control. And that has an overshoot with regards to rheumatoid arthritis. It was so successful, we thought, we've got to write this up. We wrote this up and we presented it at the IFM conference last year. So it was a case presentation accepted by the IFM. And I think accepted because you're killing 2 stones in one go. And I think this is one of the key things, understanding that if patient comes in with gum disease, it's going to be exaggerating some of the other diseases that they may be coming in for. And so that's why it's so important to get this understanding about what's going on. And the real reasons why I look at humans, and I think these are some of the fundamental functional medicine concepts that I think we all need to really get on board with. I think number one is that humans by cell are more bacteria than human.
Right,
And
yes.
so if we're not going to address someone who is sick, and we're not going to address or have an understanding about where the bacteria is, I think we're missing over half of the picture. I've seen this many, many times in clinical practice. We have patients coming in who have had a really brilliant conventional medicine workup, but again, have not asked that question. And so that's definitely something where we've looked at, well, how sick are your bacteria? And that really goes from a point of view of not just the gut, but it very much, I don't dismiss the mouth as, a different section to the gut. That needs to be found out. I think we're seeing more and more evidence from a point of view of ENT aspects of bacterial dysfunction. Yes, absolutely. Yeah. And of course, the key thing, as I point out on lectures, is that there is evidence in the literature, and this is something that we look at all the time, where gravity may be causing problems as well. There's several academic papers out there, but I can tell you from our evidence that we also deal with a lot of refractory SIBO and never seem to get rid of it. And again, I know SIBO is a tricky situation, but we always lead to the question is that, well, is this because there's a problem with regards to oral disease? And given that we're swallowing 1.5 liters of fluid a day, that fluid, if anyone's got gum disease, is going to be full of pathogenic bacteria and pro-inflammatory cytokines. Now, given that, particularly as we age, we have an aging population that are, if you like, our stomach secretions aren't as good as they should be. You're looking at, and even particularly people who are on acid lowering drugs, PPIs, etc. You're looking at suddenly, aha, this starts to make sense. So we've successfully treated SIBO, refractory SIBO, because we successfully treated the oral cavity and tried to keep on top of it. And again, this is why it's so important. I think that, so number one, this is why I think nutraceutical companies are starting to move across into, we've got to think about the oral situation. As you say, we've got to think about how we, number one, I think on various aspects, we've got to deliver enough soldiers so that they can fight off the pathogenics. We've got to deliver other ingredients that maybe are antimicrobial in nature, but also maybe help to disrupt biofilms. I think really important. I know your AuraMax does that as well. And we also want to calm the trouble as much as possible. So we want to be calming these exaggerated inflammatory and immune responses. We certainly want some degree of immune challenge. We absolutely need that, but we don't want an overly aggressive one. I think the other thing when we're looking at, and these are some of the things I'm very hot on when we see our patients, is the bacterial translocation, because that's one of the key aspects that we link gum disease.
Do you want to explain what that means?
Yeah, so look, in very simple terms, and I'll do this on a bigger picture, because I think I never want to just sort of pretend that I'm a guy who's an expert in the oral aspect. I'm not. I'm just a functional medicine clinician who, as I said to you from the story, has fallen on this because, generally because my history and an embarrassment of never knowing what gum disease is. But I never utilize this from a point of view of I'm an expert here. It's a question of how does a local disease affect my patients with other diseases?
Right.
And so one of the key things we're looking at comes back to leaky gut, if you're right. Everyone knows what leaky gut is. But I look at that from a point of view of we have these, if you like, and I'm going to use the terms, a sort of great castles that defend us from the outside world. And these great castles have these barriers. So if you think about the mouth as, or the gut, or the blood-brain barrier, they all essentially are doing a similar job. They are protecting you, or protecting the brain, or protecting the gastrointestinal tract, or protecting the mouth from the outside world. Now, if that physical structure is compromised, i.e. you've got gum recession, you've got dental pockets, you've got bleeding gums, that tells us that the structural integrity has been compromised. And what that means is that bacteria that should stay in your mouth, should stay in your gut, should stay outside of the blood-brain barrier, can quite easily come in more numbers than we would like. And when that happens, you have to have an immune response, because your immune response doesn't doesn't sort of try to work it out. It has an immediate response. So one of the key aspects with regards to, again, leaky gut is your immune system has to respond to particles and molecules that come over. Again, lipopolysaccharide is one of the key ones. And this is one of the key concepts with regards to how gum disease influences other diseases. I'm going to give you a few examples on this. There was a 2017 paper done by Texas Tech and Vanderbilt, which was actually looking at Porphyrovirus gingivalis, an oral pathogen, being a causative mechanism in the development of atherosclerosis. So how the hell does that happen? Well, basically, a bacteria that should stay in the mouth doesn't stay in the mouth, and it ends up on the arterial, on the outside of the vascular endothelium. And it really shouldn't be there. And so there are immune defenses that try to say you shouldn't be here. But as you say, as the immune system responds, it responds in generally only two ways. It increases oxidative stress, it increases immune activation, and it increases inflammation. So you get this, I call it the smart bomb analogy. It takes out the bacteria, but it also damages the surrounding areas as well. And we can see these significant changes to the vascular wall, which unfortunately then starts to bring all the other attractants when there's an injury to the vascular wall. And they are quite clear that these bacteria are not just associated, but they're calling for more studies to say that they are part of the causative factor. I can take you back to Professor Mark Houston's work on cardiovascular disease and on cholesterol. He's very clear that elevated LDL cholesterols in some part may be a direct immune protective effect against bacteria or pathogens. And so what I'm looking at on this, and it's not just from a point of view of the oral health perspective, but I'm looking at this from a point of view of gut and leaky gut, but also very much leaky blood-brain barrier, is that at some stage, you've got a very simple process. You need to make sure that there's not a raging army battling against you. You also want to make sure that you can understand the signature of that army. How much of these are just new recruits, but how much of these are real special forces that are going to cause a lot of damage? Then, do you already have compromised borders? So you've got gum disease, you've got gum recession, you've got periodontal pockets. You are going to be accelerating the ease of this bacteria getting into your system, essentially. Yeah, and look, these are some of the mechanisms, this bacterial translocation, some of the mechanisms that we're seeing in many diseases. One of my associates, Despina, she's IFM certified as well. She did a recent research study looking at Fusobacterium nucleatum, which is another, we're sort of looking at this maybe as more of quite a strong oral pathogen, and it's implicated in breast cancer. So again, look, we're looking at here, how the hell does a bacteria that should stay in your mouth ending up in the breast? And it's because it translocates. It has this capacity to move because you're giving it open doors. And this can happen in the gut. This can happen on joint surfaces, particularly rheumatoid arthritis. Again, pathogenic bacteria getting to places that they shouldn't do. And again, rheumatoid arthritis is really interesting because Porphyrovirus gingivalis as a molecule carries a lot of LPS with it, but it also carries these things called gingipains. And these gingipains seem to have this ability to citronate a lot of proteins. So we are seeing potentially Porphyrovirus gingivalis influencing the anti-CCP levels as well. So I don't fully understand the full literature on it, but we know that PG is definitely a player in that. And we're very clear that Porphyrovirus gingivalis is a player in the infective aspects of Alzheimer's.
Yeah. So is the same bacteria, like this one bacteria, do you see all the different things, or there are different bacteria that you see associated with different diseases? Because you mentioned Alzheimer's and cardiovascular disease. I think what you're going to find is that Porphyrovirus gingivalis seems to be the main pathogen that the research is showing us. But we're going to see other ones that I believe are going to show very similar mechanisms and very similar results across probably many diseases. They may be slightly more isolated. And again, I think as more research comes out, and it's a real hotbed, Debbie, now of research. But I think what we're very clear on, I think it's not just about the bacteria, it's about border control.
It's about bacterial translocation. It is about immune system responsiveness to something that shouldn't be in a place that it is. And your immune system is only doing the job that it's designed to do. It's going, you definitely shouldn't be here.
Shouldn't be here, right?
Or I'm going to clear you out. And I find this really very, very interesting, because I recently did a brain health conference in London at the end of September. And I was really trying to get them to understand that one of the things that we're definitely clear about on Alzheimer's is that for some people, it's fundamentally an infectious disease. It is a disease where we might be seeing, and I'm going to use oral pathogens because it's well studied, and we know there's a strong relationship, but some of those oral pathogens have had the capacity to translocate from the mouth and get through the blood-brain barrier. And then, of course, when they've entered into the brain's immune system has to challenge them.
Right.
And so you're getting these patients where they're almost consistently showing a neuroinflammatory response because the borders are always compromised. And there is always a place where, again, this comes back to, we could take this right back to looking at the lifestyle. The lifestyle is always compromising what is happening in the mouth. Poor dental health, poor choice of foods, poor lifestyle are all dictating that you may have an increasing oral dysbiosis that is increasing your odds of having more bacterial translocation, and then is increasing your odds of those bacteria ending up somewhere else, and then the immune system is responding in the way where it is damaging the body over time. Now, you're going to have people who have more susceptible genotypes from a point of view of how their immune system is going to respond. And that, again, was part and parcel of what I wanted to understand more with DNA Smile, because I wanted to understand, well, who are going to be the canary in the minefields? There's a very interesting paper when we're looking at Alzheimer's from an infectious disease, written by a couple of dentists. I actually think it was a 2021 paper. I can't remember where it was from, but I think they were dentists from Florida. What I found really fascinating about this paper is that they were sort of suggesting that gum disease is a disease that you get early. So it's developing in its 20s. And for some people who have very poor oral health and maybe poor genetics, interdisposed with poor lifestyle, that already may have started the signs of gum disease in their 20s. What the paper is proposing is that you've got two separate diseases. You've got gum disease, which generally is a disease that we can see early on, 20s, 30s, 40s. And then you've got Alzheimer's, which is generally a later disease that gets really diagnosed, if you like, 60s, 70s. Although I saw a recent lecture by Dale Bresden suggesting that actually we're seeing more and more people in their 50s. But what I found incredibly interesting, and it's something that I take forward for all of our patients, is that they wrote a really nice summary to say, look, we have this opportunity to influence two diseases, but also influence a disease that develops later, because we can stop a lot of the toxic and infective assaults on the brain by dealing with gum disease much earlier.
Right, start with preventative care.
So if you, of course, Debbie, the problem with that, of course, is prevention's a bit of a dirty word, because people are going, well, why do I need to do it now? When, I don't really have that problem. And so, what we've done with a lot of our patients is we're identifying, again, I did a really good presentation on a patient where we're identifying the canary in the mines. We're identifying the E4, E4 genotypes with pro-inflammatory genetic signatures that may already have one or two comorbidities, but also have poor oral health. And again, what we're trying to say to them is say, look, we need to, I know you've come to us because you're worried about, whether you're going to get Alzheimer's, but this is something that we need to do now. We need to be working on that. And what I can say on that, I'm going to do a case one intervention on this. But when I got that news that I had really quite not severe periodontal disease at the back of my mouth, but moderate to severe periodontal disease, Debbie, I was completely asymptomatic until that tooth, and that was 45. So
Right.
I
I
had
mean, that's interesting. You're completely asymptomatic and no other comorbidities. So I have
no
no idea.
idea. And of course, again, not poo-pooing the dental hygienist or the dentist, because this is new to dentistry as well. They didn't even, they always said my teeth are fine. Come back in 6 months. They look all fine. There's all right. You got a bit of gum recession. You've got a bit of some tricky biofilms that will scrape off, but really never too much of a problem. And yeah, as you say, it was slowly and insidiously developing. Now, if I hadn't gone and done all the research that I did and actually started to look after myself, my gum health is much, much better, in much less pronounced. Now I've got very sort of slight periodontal disease, but I've completely, I believe, slowed that process down.
And what is your process when you, what is your treatment protocol?
Well, look, I think there was a couple of things that I needed to do. The periodic oral bacterial testing, I think, is very important. I obviously use my own genetics panel, so I can see on that how I can normalize things. We've done quite a lot of genes. We've looked at basically some of the main innate and acquired immunity. So I'm very much interested in that border control, stuff like the influence of toll-like receptor 4, which again is one of these fundamental immune, if you like, I call it a sort of the guys that are looking out to see what's happening before the war starts. And I find toll-like receptor 4 really interesting because, of course, toll-like receptor 4, where there are gene variations, toll-like receptor 4 sees saturated fats as a pathogen. So in susceptible genotypes who maybe are working down an Alzheimer's protocol and have suddenly been told that saturated fats are absolutely fine and you should have more and more in your diet, you can sort of see the subtleties of how you're moving toward more precision medicine. And of course, toll-like receptor 4, we wanted that because we wanted to see the gene variations because it tags LPS. And of course, a lot of these oral pathogens are gram negative and they're going to be carrying a lot of LPS across. And so again, not only are you getting the bacterial pathogens to deal with, you're also getting the LPS activation as well. And so I was very much interested in that. And so the gene panel has really given me a better idea of how I could treat myself locally and what's going to work. Like, as you say, the Oramax from a point of view of green tea, the cinnamon, etc. What are the strain-specific bacteria that we can use? Now, the great thing about that is now, like companies like yours have really gone on to start to look at the research and say, okay, well, this makes it easier. But
a combination product, essentially.
Well, it is a combination product, yes.
Putting things together.
But what it also tells me, again, is that there is a bi-directional relationship. So I've got to know both, are there things in my life that may be from a systemic picture are making the gum disease worse, and the gum disease is making the systemic picture worse. So it's understanding that in as good a personalized a detail as possible. And then, of course, it comes down to the day-to-day treatment. So I'll give you an example of what I do. And Debbie, I look at this, I think I was having a conversation with quite a lot of people that think that functional medicine might give them all these new great answers and it's going to be dead easy to do. And the reality is that it can give you some incredible answers, but it's hard yards on a daily basis. So I find that I have to do a lot of work on looking after my teeth. I'll take something like Oramax, maybe twice a day, so that I'm always making sure that I'm trying to keep that bacterial area clean. Balance. And then periodic testing, certainly on the oral bacteria. That once you do the DNA, you only ever do it once. But also look at those DNA results and start looking at some of the gene variants and whether we can associate those with lifestyle interventions. So we've looked at some of the matrix metalonase proteins. We've looked at the MMP3, which is very highly associated with the acceleration of gum recession and the collagen matrix, and the breakdown of the periodontium, and so we're looking at that, and also again looking at people who have some real gene variants on that, because we're going to see an acceleration of the breakdown there. And that's where we can start saying, well, maybe you're a candidate for collagen. Again,
okay.
not much research on it yet, but theoretically and based on a precision and personalized data set, it makes sense that we could start saying this is for you. But
what about vitamin C and its role in
well,
collagen?
look, I think there's a lot that we can look at. So, you know, if we're going to use collagen, I always like to use additional vitamin C. But there's a way that you can, as I say, you can treat locally, but also then think about what do we need to treat with this person systemically. And there are so many, again, you know, there are so many nutraceuticals, so many natural products. Again, you're using green tea. I think green tea extract scientifically has a lot of validation, antimicrobial, antibiofilm. There's lots and lots of things that you could look at. And I think we're starting to look at products where we can use them localized, but then also thinking about, well, I've got to do a localized aspect, but I've got to do a systemic aspect as well.
Right.
And we've got to think about how all those fit together. But trying to explain that to a patient that suddenly comes in for an Alzheimer's protocol or cognitive decline or something else, that why are we talking about that? And again, that is because the relationships are so strong. And that's been difficult for us to get over. We've developed some forms which allow it to make it much easier for us to say, look, at least we can start a conversation. But they've got to do something. And I think, again, starting with something as simple as, well, at least we're doing something with a product like Oramax. It's allowing us to say, okay, well, that's good enough for now. What are the next steps that we need to do? What is the data that we need to collect so we're getting a better understanding and a better picture? And I think, as I say, for someone who looks at this area quite closely, it is really ramping up in not only just the dental world, but also within the functional medicine world. And I think it's absolutely, you know, I think the mouth is the new gut, but I don't separate them because
well, I mean,
again,
they shouldn't be separated, right? I mean, they're all one thing. You have to go through the mouth to get to the gut.
And I think this is historically how I think we've separated medicine, we've separated systems. They're all interconnected. And, you know, we can't rely on the dentist to give you good advice. And in fact, I work with certainly some of the, I mean, Dr. John Roberts in particular, he's one of the most eminent biological dentists worldwide. And even John will tell you is that there are things that he can do and the things that he can't do because the legislation by the British Dentists Association, they won't allow you to do it. And of course, he will lose his license if he does anything that doesn't seem like standard practice. So we've got to be incredibly careful. And I think dentistry is being held back a little bit because there is only so many things they can do. And it's very, very restricted with, of course, what they can say. And so we're trying to build the bridges there to say, hey, listen, this is not separate. Dentistry has to be amalgamated in with some kind of functional medicine or systems approach. And we're definitely seeing some dentists in particular who were suddenly going, well, yeah, this is completely normal, you know, for us to amalgamate that, you know, you do this, we'll do this, and we'll amalgamate what we're doing in the middle, which we've done.
Are they able to tell patients about the systemic
they
connections?
Yes, they are allowed to cite the research.
Right.
But
okay.
I think where they start to get into trouble from a license perspective is when they start to come up with kind of some therapeutic approaches that are more than just general good lifestyle advice. Now, again, in general, good lifestyle advice will get you there, but for them to maybe even suggest something like Oramax or something like that in certain circumstances, I don't know how tricky that is from a point of view of license. But this is an industry that's massively changing. So I think, again, as we come into this, we get this understanding of the greater good. I think it's going to be more and more apparent that this is the absolutely right thing to do, and dentistry needs to connect up. And I'm absolutely out there to help anyone dentistry wise to say, yeah, you know, I mean, I don't know what it's like in the US. Maybe you have a better idea of where.
Yeah, I mean, we do have biologic dentists, and we're starting to talk to them and trying to connect with them in terms of. But I don't know if standard, traditional dentists do that. So I think there is kind of a split, and there is an organization of biologic dentists too.
Yeah, I'd say that. I look at that from a point of view of, I mean, again, I don't want to dismiss my dentist, is that she just wasn't aware of a lot of this research. So, you know, it's no fault of hers. And again, as you say, 8 years ago, I was not aware of this at all. And so, but, you know, I'm very, very clear that this is standard practice of any patient that comes into us to at least ask that question, you know, well, what's the standard of your dental health? And, you know, and really, you know, challenge them with regard to what's been done, how's it been done, because I know how it influences. The research is overwhelming, really profound research. And as I said to you, when we're looking at Western populations, you know, once you started getting over 50, you're talking more than 50% of the population.
That's a high number.
It's enormous. I mean, more than anything else that I've seen as far as any disease. And it's going to have some degree of influence, whether it's associated, whether it's causative, with other diseases. And so we can't ignore it. And so, as you say, David, I don't know if you know David Furman. David Furman is a scientist up at the Buck Institute, Nevada, which I don't know whether you're aware of the Buck Institute. It's a private institution. It's a health institution, predominantly looking at longevity. Dale Breseden, I think, maybe the head of it. But he wrote a really good paper in Nature Medicine in 2019, talking about really how we need to look at diseases as not separate, but they're all interlinked. And these diseases are interlinked through the predominant mechanism, which is inflammation. And so, you know, what I took from that paper was, well, what he's saying, which makes complete sense, is that if you can deal and understand the underlying mechanisms that drive a certain disease, they're going to be pretty similar mechanisms that are driving other disease processes. So
that makes a lot of sense in terms of
course it does. You know, you start to, you know, kill two birds with one stone, which is, you know, a process that I look at all the time. And the difficulty is just getting your patients to buy into that storyline, because it seems so fantastically way out there that, you know, you've got to be a really good storyteller to say, look, this is why this is important. And I know you've come into me because we're trying to deal with some kind of cognitive decline, but that cognitive decline may be associated with what's happening in your mouth. And so we really need to do something about this, and we need to do it now so that we are controlling that and saving you for a later date. So look, I think that's where we're at. I think
we're going to need to wrap up soon, but I had just a few more questions, and then
sure.
Anything else you want to sum? What about candida? Is there any kind of concern with like yeast or candida in the mouth? Because some people get that overgrowth and get thrush, and I see that in kids all the time.
They do. Offhand, I don't know whether that, well, it will clearly create a dysbiotic oral microbiome for sure.
Yeah.
And that would probably increase more of a pro-inflammatory sort of environment. So I suspect, I don't know the literature, I'll definitely find out. I suspect that's problematic, and that needs to be dealt with, in my opinion.
Right, because I see a lot of people have the dysbiosis candida overgrowth, and then
course,
you can actually see it on the tongue. You can see the overgrowth.
So I would want to deal with that. Yeah, I would be thinking about that within that picture for sure. And again, when we're talking about bidirectionality, when you're looking at diabetes and type 2 diabetes, well, actually some of the pro-inflammatory cytokines, in particular IL-17A, and it seems to have a direct effect on making the oral microbiome more dysbiotic. So again, there's another angle of, if you deal with the diabetes, it helps the gum disease. But if you deal with the gum disease, it helps the diabetes as well. So again,
just the elevated blood sugar and kind of the sugar influence on like candida overgrowth.
Of course, yeah, absolutely on that. And again, you know, the increase in sugars have a massive influence with regards to changing that microbiome environment. And in DNA Smile, we look at actually 2 genes that are associated with sweet tooth, because
I saw that.
Yeah, it's good because we want to get that understanding of who's going to be predisposed.
Right.
And so, yeah, I think, again, particularly, I wanted to do that, not just for the mouth, but again, we see a lot of type 2 diabetics, a very strong association with it. And again, you know, we have patients that are smokers as well, and the type 2 diabetic.
That was my question too, smokers or alcohol, which is basically sugar.
Yeah, I think the most damaging thing you can ever do to accelerate gum disease is smoking, by far. You know, I think we're all aware that it is a pretty damn damaging thing to do.
Even the vaping is a big thing now, and I see it with the young people.
So again, on that, I don't know, but I suspect we're going to see similar results with regards to vaping on gum disease. Yeah. I don't know if there's any research on there. Again, it's a brilliant question. I'll go away and have a look at that. I suspect, though, we're going to see similar mechanisms with the vaping. Yeah, maybe not as strong, maybe not as advanced, but you know, when you see a type 2 diabetic who's a smoker and you do their DNA health panel and you sort of their DNA smile panel and you go, wow, okay, this one is going to, if we don't do something about it now, this one's going to accelerate away very quickly.
Right. Metabolic, obesity,
absolutely,
you know,
and it's all in that catch-22 situation. So you've got to deal with it because this is part and parcel of the diabetic obesity picture as well. Right. So they're highly linked.
Yeah, and as I said, I'm a pediatrician by training. So my question, I've seen a lot of kids. I see kids even with like the breast milk and have terrible cavities and terrible oral health. And so when you say it started in the 20s, I'm like, well, what about poor health if even in children?
Yeah, it would make sense to me that there is a strategy both systemically and localized to do some degree of treatment there. Absolutely. You know, I think we could take it all the way back, can't we? We could take it back to mum's pre-pregnancy health. We can take it back to, you know, where was mum in pregnancy? Was the baby C-section? You know, was it breastfed? You know, were sweet foods introduced at certain times? You know, was it antibiotic treatment and done early on? So did that child really establish a nice microbiome before we were started? I think there's it. I think absolutely on that. And I think also, Debbie, I would be looking at, and again, this is something I never knew anything about, but some dentists have really helped me out, the structure and the anatomy of the jaw.
That's true. Some of these kids have like really malformed jaws or.
Yeah, and whether the child is mouth breathing as well. This is definitely one of the interesting things that I've learned is that we get these patients who, when they come back, like, Pete, I can't do anything more than you've asked me to do with regards to my oral health, but I'm still on testing looking pathogenic. And again, that's when we start to see that, oh, okay, hang on, you're not snoring at night, are you? Yes, I am. And you're like, right, okay, the risk
is... What about the sleep apnea, would that be?
The sleep apnea, again, has a double whammy. Not only does it dry the mouth out and you don't get the really, really positive effect of saliva. I've been overwhelmed with just how many compounds are in saliva and how protective they are, because that also leads, Debbie, to the patients who are maybe on diuretics in particular. So I'm always very, very, I really want to know whether, particularly from an oral perspective, whether we've got a patient on a diabetic medication, because that definitely will have an influence. And they'll lose that protective mechanism of saliva. So again, some of the very simple questions. Are you waking up in the morning with a really dry mouth is for me a sure sign that, okay, this is something we need to think about on here. And of course, sleep apnea has a massive, I'm going to say that massive, so that's wrong to say, is increasingly becoming more important with regards to brain degeneration and Alzheimer's disease as well. So I think the literature again is becoming more and more apparent on that one. So mouth breathing at night, definitely a sign that we need to think about both. And again, this starts early. You know, I want to be looking at, I suppose as a pediatric, from a pediatric perspective, it makes complete sense that we've got to do something. It's a question of where do we start? And, you know, I'm always lifestyle first. It has to be that, because I think they're the pillars of health, and that's where you're going to get the biggest bang for your buck, and it's usually free. But it's a question, but it's a question of how you take that patient down a journey and what are they capable of doing at any one time. And for some people, the probiotic mouth, you know, the Oramax is the best.
That's really easy. You know, that's easy. You put it by your sink, you know, you brush your teeth, you take it. I said that's, you know, for children, especially thinking about that.
And I think that's it's a step forward for me. So that's how I look at it, is that, you know, there's lots of stuff that we've got to do, but we've got to get you on the path. And whatever that is that it's a positive step forward. So if it is, you know, Pete, I'm so busy at, you know, the Oramax is the first thing to do. I think, well, okay, at least it's it's doing some good, and we'll be able to measure how well it's done over a period of time.
I know, I like that in terms of knowing about the testing. That's great. So
Yeah.
we're going to need to wrap up. So I don't know if we have anything, kind of a summary to say.
I don't think so. I think
I don't think so. We've covered the subject.
Yeah, but I think hopefully what we'll do is we'll bring a deeper understanding that we do need to think about the mouth.
Right.
We do need to protect the mouth. We need to think about the dysbiosis. We need to think about the barrier dysfunction. And we also need to think about maybe how the immune system is going to react to who's on the battlefield. And I think for clinicians, I think it's absolutely, if I can give you a tip, then at least just ask the question, you know,
Right.
What is your oral health?
Well, I mean, in functional medicine, we are taught, you know, literally, you start with the diet, but you start with the gut, right? That's like the first thing you address. So it makes so much logical sense to me that the mouth is like the beginning of the gut digestive system.
Agree.
So if you're addressing this, but you're not addressing the mouth, you're really not fully addressing the gut. So I think that if you explain that to people, I think it sounds very logical to me.
And I don't think this is new, because when you start to look at the literature, it's really overwhelming in the literature. I couldn't believe just how much is going on in the literature with regards to these bidirectional connections. I'm really enjoying how scientists are now embracing systems biology thinking. There's a really wonderful paper that I'll link you to in Nature Medicine last year, which was the most beautifully narrated and diagrammatically done paper with regards to gum disease and systemic diseases. So again, I can send you a link to that, because I think
yes, that would be great.
It's a fantastic paper that you'll go, wow, you know, scientists are really starting to join things up. It's brilliant.
Yeah.
So
and if it becomes in generalized medicine and traditional medicine, if that's even better, because then people will know and understand that, you know, so we want to explain itself. So
we're on the turn, which is great.
Yeah, I want to thank you so much. I've learned so much, and I really think people are really going to educate, and that information, it makes so much sense. And I think it's really important that anybody in integrative or general medicine learns that, and people too understand that component of health. So
great, Debbie, it's a real pleasure.
Yeah, thank you so much for joining us.
Thank you.
Okay, bye-bye.